The first thing to say is that it's a very, challenging and controversial topic. Some people just think that perfusion imaging is just a waste of time and is not useful to select the patient for any reperfusion therapies, but other things that perfusion imaging can help to select the good patient for the good treatment in a way to do personalized medicine. So basically the aim of perfusion imaging is first to help to make a positive diagnosis of stroke. So as you may know, many acute stroke codes in fact are not acute ischemic stroke, but are stroke mimics. It's 15 to 25% of acute stroke, so it's a very frequent situation. And in this situation, perfusion imaging is extremely valuable, helping to evaluate if the patient has or not a hypoperfusion, which is typically seen in acute ischemic stroke. There are two main techniques in day-to-day practice. Most of the centers worldwide use CT, so we can use CT perfusion, which help to delineate both the irreversibly damaged tissue, which is the core, using perfusion, using CT perfusion, using the commonly used is the relative cerebral blood flow less than 30% threshold, and it also helps to delineate the severely hypoperfused tissue, which is evaluated using Tmax maps above 6-second volume. Then when you have both these volumes, you can just make a subtraction and get the penumbra, which is the severely hypoperfused tissue, but whose fate will depend on the occurrence of recanalization. And typically this is a target of any reperfusion therapy. And the other imaging modality is MRI, which is done in some centers. For example, in France, we mostly use MRI in the acute stroke setting. And using MRI, the core evaluation is not done using perfusion, but is done using diffusion-weighted imaging. So perfusion only brings the information of critically hypoperfused tissue, and therefore using both diffusion and perfusion imaging, we can get the evaluation of the penumbra volume, so the tissue which is at risk of infarction and which is a target of acute stroke therapies.